Good morning, ladies and gentlemen, and thank you, Chaturanga, for the kind words of introduction. So I think you heard about overall about the diabetes management, the HbA1c target, the blood pressure target, and everything. So let's now look at a specific thing, that is how to pick the correct oral hypoglycemic agent. I think this is a question that everyone has. So I'll be focusing only on type 2 diabetes. Obviously. So when it comes to the pharmacological management or the glucose control, there are three types of medications you can use. That is the oral hypoglycemic agents, then the non-insulin injectables, that is the GLP-1 receptor agonists such as the liraglutide and exenatide, and then you have your good old insulin. And if you look at the history of anti-diabetic agents, the insulin was the first that came into the market. And then out of all the oral hypoglycemic medications, sulfonylurea was the first commercially available oral hypoglycemic agent back in 1956, followed by metformin. And then after that, there have been so many other anti-diabetic agents like acarbose, thiazolidinons, GLP-1 receptor agonists, DPP-4 inhibitors like sitagliptin, and the newest ones like SGLT2 inhibitors. So, so the question is, which type of oral hypoglycemic agent you are going to use in your patient when you come across the patients with type 2 diabetes. So, to make the matters worse, so you get complicated guidelines like this. So this is, as you can see, it's a very crowded slide and very complicated. So it looks complicated, but let's see. I'll try to break it down and show you how to choose the correct oral hypoglycemic agent. So because of this multitude of drugs available, so it leads to the therapeutic inertia. So you're left with the question which one to use. And so at the end of the this talk, I hope you will have some idea. So, so when you're choosing the oral hypoglycemic agent, it depends on several factors. The first one is the what is the HbA1c reduction by the particular oral hypoglycemic agent you are going to use. Is it going to achieve your desired target of HbA1c in your patient? As Chaturi mentioned, the general target is 7%. So is this drug is going to reduce your patient's blood sugar to the optimum or the desired level. The second one, you have to something wrong with the so it's going automatically. So the second one you have to look at is the other comorbidities, that is such as the presence or absence of other cardiovascular diseases or particularly renal and cardiovascular disease. And the third one you have to consider is this drug going to cause weight gain or weight loss? You know that the patients with type 2 diabetes, one of the major problem is the obesity and the insulin resistance. So are you going to, is this drug going to help reduce weight, or are you going to cause more weight gain in this patient is the third factor. And then minimizing hypoglycemia is also very important, because I think most of you have seen in your practice at some point patients on oral hypoglycemic present with hypoglycemic episodes. So you have to reduce that. And then finally, at the end of the day, in countries like us, probably the cost is the thing that you have to come to, is the most important thing when you are actually picking the oral hypoglycemic, particularly with the economic crisis. This is more relevant today. So, so just to summarize the classes of medications available, you have your biguanides, that is your metformin, and then you have the sulfonylureas, and then you have alpha glucosidase inhibitors, and then thiazolidinons like pioglitazone, and then the DPP-4 inhibitors like sitagliptin, and then SGLT2 inhibitors like empagliflozin. So let's go through some cases. So the first patient is a 45 years old banker who presents with osmotic symptoms for 1 month duration, and his BMI is 29.5, that is he's towards the obese side, and the fasting is 256 and HbA1c is 9.5%. So when it comes to, so this patient, you have to answer two questions. So what is your glycemic, you have to achieve the glycemic control, and then probably because he's a obese person, which has probably contributed to his type 2 diabetes, you have to promote weight loss or at least avoid weight gain if you can't promote weight loss. So I think I won't go through this. So it is, the HbA1c target. So in a ideal target is 7%. So in a patient like that, probably you can go to a HbA1c target of less than 7%, even probably even 6.5%. So why do we talk about this HbA1c all the time? Why it is important? So this data from the UK-PDS, that is the early intervention trial in type 2 diabetes, and this is data from their 10-year follow-up study. This study showed that 1% reduction of HbA1c actually reduce all the mortality and morbidity associated with type 2 diabetes. So if you look at here, so you can see microvascular diseases were reduced by 37%, PVD by 43%, strokes by 12%, myocardial infarction by 14%, and all-cause mortality by 14%, like so on and so forth. So you can see that 1% of reduction in HbA1c in your patient, particularly at the beginning of diagnosis, will help to reduce all the complications. So similarly, in this DCCT EDIC or the long-term follow-up trial in type 1 diabetes, it also showed that the HbA1c level of HbA1c is associated with relative risk of microvascular complications like retinopathy, nephropathy, neuropathy, and microalbuminuria. So you can see as the HbA1c goes up, the relative risk exponentially rises. So you need to reduce the HbA1c. So let's look at the glycemic potency of different drug classes. Here I have summarized the HbA1c reduction by different drug classes. I have to mention insulin I have used as a comparison, but it will reduce the HbA1c more than 4%. This is just for the representation. But if you look at the other oral medications like metformin and sulfonylurea will reduce your HbA1c by about 2%, and then 5-litisone by 1.4%, acarbose by 1%, and the newer classes actually will reduce your HbA1c by about 0.8% or something around 1%. So it's not a big reduction, but they might have other benefits in your patient. So if you look at the guideline, so metformin is still the preferred initial agent, and the recommendation is to, if there are no contraindications, to start with the metformin, and then if the control is not adequate, you can think about adding on other agents to on top of metformin. That is the usual guideline, but some guideline now coming up saying that you don't have to go with metformin, but at the moment we are metformin remains as the initial therapeutic option. But the problem with metformin is the kidney, but have to mention, you have to always reiterate to the patient that it doesn't cause renal failure, but it might have to be stopped when there is renal failure. But you can use metformin when the GFR safely you can use up to a GFR of up to a eGFR of 30, and when it is less than 30 only, you have to stop metformin. But less than 45, but more than 30, then you have to reduce the metformin dose to 1000 milligrams a day. That is the half dose of the maximum effective dose, which is 2 grams per day. And when you look at the cardiovascular safety, there is, as I showed in the initial slide, the UK-PDS study showed that there is cardiovascular safety, but those days we didn't have all these cardiovascular safety trials as like in the newer drugs, so we don't know much about that. So when going back to our patient, so we started the patient on metformin plus lifestyle modification. Here I have to mention, so the lifestyle modification alone is expected, if done properly, will reduce the HbA1c by about 1 to 1.5% or even more than that if the patient is really dedicated and do it properly. So this patient, even with metformin and lifestyle modification, after 3 months there was no significant weight loss, and HbA1c remained at 7.8%. So what is your next drug of choice? What is the next oral hypoglycemic agent or any other one that you are going to use? So what does the guideline say? This is from the complicated slide I showed. So if your aim is to minimize weight gain or promote weight loss, preferably you have to start the recommendation is to start a drug which shows which causes weight loss or which has proven to cause weight loss. That is either a GLP-1 receptor agonist or a SGLT2 inhibitor. I will explain what are those drugs and how it works. And if your HbA1c target is not achieved by adding one of them, then you can switch and see. That is, if you added a SGLT2 inhibitor first, then you can try with the HGLP1 receptor agonist, and vice versa. And if both are not tolerated or indicated, then you can cannot be given. Then you can consider a DPP4 inhibitor, which is actually a weight neutral medication. It doesn't cause weight loss. It is weight neutral, so it won't cause weight gain either, because there are other drugs like sulfonylureas and thiazolidinase which causes weight gain. So out of all the medications, when you want to reduce weight or not cause weight gain, probably the DPP4 inhibitors and SGLT2 inhibitors are the best options available out of the oral medications, because GLP-1 receptor agonist is the injectable, not an oral. So let's briefly look at these medication classes. So these the GLP-1 receptor agonists and the DPP-4 inhibitors belong to the class called incretin-based therapy. What are these incretins? Just to I think this is not shown there, no, the arrow. Yeah, so if you look at the circle, so GLP-1 and GIP are the two incretins which are occurring naturally in our body, which increases in response to the oral intake of glucose, and their action is to increase insulin secretion by the pancreatic beta cells, thereby increase the glucose uptake by the muscle cells and reduce the blood glucose level. And also it reduces the glucagon secretion, thereby reduce the glucose production by the liver. So GLP-1, there are GLP-1 receptor agonists which are produced based on this, like liraglutide and exenatide. And then also we have the and these naturally produced incretins are actually degraded by the DPP4 enzyme, which is produced naturally. So what they did was they produced a DPP4 inhibitor, that is an enzyme, a drug that inhibits the enzyme called DPP4. That's why it's an inhibitor. So thereby the naturally active incretins will work longer. So if you look at the GLP-1 receptor agonists, these are the GLP-1 receptor agonists. They are almost all are injectable, so it's not relevant here in my talk. But I have to mention the semaglutide. There is oral formulation is available in other countries now, but it's not still available in Sri Lanka. And I don't think it might not be available in a recent past, because it is going to be very costly. Even the injectables are very expensive, and only some people can afford, because it's going to cost you a lot. So what is the benefit of this GLP-1 receptor agonist? Because it has well shown to reduce weight in patients with diabetes and without diabetes as well. And it has shown to reduce the cardiovascular mortality. I think it will be dealt in the lecture later on. And there is no risk of hypoglycemia. That is the added advantage. And it reduces the HbA1c somewhere around 1. So, but the problem is it's expensive and it's an injectable and can have some GI side effects as well. So, what are the DPP4 inhibitors? The DPP4 inhibitors, I think everyone is familiar: the sitagliptin, vildagliptin, saxagliptin, linagliptin, and alogliptin, and 3 of them are available in Sri Lanka. And again, they are proven to be net neutral, or more like weight neutral, not really weight loss. It doesn't really cause weight loss, and it is a well tolerated drug, and there is no risk of hypoglycemia unless you use it in combination with insulin or other sulfonylureas. And except linagliptin, however, they need renal dose adjustment in the presence of renal impairment, and the cardiovascular outcomes are neutral with this drug. So let's look at the other class of medication that causes weight loss. That is the SGLT2 inhibitor. I think most of you are familiar with newer drugs like empagliflozin and canagliflozin and dapagliflozin, which are available in our market, and I think the prices are coming down, so they are also freely available now in our country as well. So how do they act? If you look at your nephron, there is something called SGLT2 transporters, that is sodium glucose 2 transporter in the proximal tubule, and whatever out of all the glucose that is filtered through the glomerulus, 90% is reabsorbed by this SGLT transporter. What this drug does is this reabsorption is inhibited, so that all the glucose is lost with the urine of the patient. So in such patients, there is no point looking at the urine full report for sugar. I have seen some patients come and say, the doctor said the urine sugar is there. You have sugar in your urine, but the patient is actually on SGLT2 inhibitor, so no point checking that in that kind of patient. So and that is their main action. So they reduce the glucose, plasma glucose by that. And there is evidence to suggest that this significantly reduce the weight in patients with or without diabetes. And the risk of hypoglycemia again very low, and is usually convenient because once daily dosing, and it has good cardiovascular outcome, which again I will not discuss, as there will be a separate lecture on that. And there is improved renal outcomes as shown in some studies. So, but you have to remember that they have some bad side effects. So there might be increased risk of amputation and fracture, particularly with canagliflozin, but this is a bit controversial. But we commonly see the genital infection, and they can have severe infections like Fournier's gangrene also. So you have to be aware, and you have to ask the patient these kind of things every time they come to you. And if they are getting recurrent UTI, probably you have to stop this drug. And the another side effect is the euglycemic ketoacidosis. So you have to keep an open mind in order to detect that, because the patient will have ketoacidosis, but the blood sugar level may not be high as what you see in the normal patient, normal decay. Okay, so let's go back to our patient. So as this patient didn't reduce weight significantly, and HbA1 remained at 7.8, and we expect his HbA1 to be less than 7%. So we decided to start him on a SGLT2 inhibitor. GLP-1 receptor agonist can be considered if it is affordable and if the patient is willing to take a injectable. So in this patient, the second option would be either SGLT2 inhibitor or a GLP-1 receptor agonist, and if both cannot be used, then can't afford, then probably you can try with a DPP-4 inhibitor, that is your sitagliptin or a linagliptin or vildagliptin. Okay, let's move to the next patient. It's a 72-year-old male who presented with history of hypoglycemic episodes, mainly in the night. And his fasting is around 180 with HbA1c of 9%, and he has slightly reduced EGFR of 58, and microalbumin urea is there, but not very significant. BMI is 22, so he's a normal average build person. He's on metformin 500 twice a day and glibenclamide 7.5 BD. So the questions in this patient are, what is the HbA1c target you are aiming at? How are you going to prevent further hypoglycemia? Are you worried about the weight in this patient? And what about the renal functions and renal safety? So if you look at the guideline, this is again from the guideline. So if you want to minimize the hypoglycemia, you have to give a drug which has less risk of hypoglycemia. So all the drugs that I already discussed, like DPP-4 inhibitors, GLP-1 receptor agonists, SGLT2 inhibitors, they all have very low risk of hypoglycemia. So you can choose any of them as the second line agent in this patient. In addition, you can go for pioglitazone, that is your thiazolidiniols. But if you want to use sulfonylurea, then probably you will use a second generation sulfonylurea. So these are the options that are available. So let's look at the sulfonylureas. So there are conventional sulfonylureas and the modern sulfonylurea. The conventional sulfonylureas like glibenclamide, I think many of us are not using. I think none of the endocrinologists are prescribing, but there are some patients who are still on that. You have to be very careful, because they are drugs like glibenclamide, which has longer half-life, are likely to cause hypoglycemia, particularly elderly patients. So I will skip this given the time. The sulfonylureas are all similar in efficacy, but the problem is longer acting ones like glibenclamide might have hypoglycemic risk, but the newer sulfonylureas are having less risk of hypoglycemia. And another problem with sulfonylurea is they can cause weight gain. So this would not have, that's why we didn't consider this in our earlier patient. And the renal safety, you don't have to worry about the renal functions when you are giving sulfonylureas. But the problem is, again, there is risk of hypoglycemia in the presence of renal impairment. So you might have to adjust the doses. And there were questions about cardiovascular safety, particularly with drugs like glibenclamide, but relatively considered as safe. So just to quickly run through the other classes, the pioglitazone is the thiazolidinone which is available. It's a very good drug and it acts as an insulin sensitizer, but usually it is limited by its side effects because it can again cause weight gain and it can cause worsening of heart failure and can worsen macular edema if the patient has retinopathy, and it can increase the fracture risk. And bladder cancer, I think it's a controversy. I think later proven probably not there. So it should not be started in patients who have heart failure already, those who have renal failure, those who have who are obviously pregnant, and those who have macular edema. And if the weight is a problem, and again don't start pioglitazone because it's going to cause weight gain or due to the water retention. So going back to our patient, we decided that it's a HbA1c target as less than 8% because he's an old person with hypoglycemic episodes. So we are happy with HbA1c of less than 8%. So in order to prevent further hypoglycemia, we can stop glibenclamide in this patient and then probably add a DPP-4 inhibitor or a sulfonylurea like glycoside, which has low risk of hypoglycemia. So, and also it's important to prevent weight loss. So better not start drugs like SGLT2 inhibitors. Renal, we have to think about the renal safety when starting any of the medication. The next patient is, it's a 54-year-old male with type 2 diabetes, presenting with a history of non-STEMI with a HbA1c of 8% and eGFR of 68, and he's on metformin and glimepiride maximum doses, and he has a BMI of 26. So again, the same question: what is the HbA1c target? What about the weight? What are you going to do about the weight? And what is the cardiovascular safety or benefit? Again, the guidelines suggest if there are cardiovascular risk, that is, the patient has adverse cardiovascular disease or indicators of high risk, then you have to go for the GLP-1 receptor agonist or a SGLT2 inhibitor. As there is a separate lecture on cardiovascular disease, I will not go into detail. So there are ample evidence to suggest that the cardiovascular outcome trials have shown that the GLP-1 receptors agonist and SGLT2 inhibitors actually have cardiovascular benefit, not neutral. That is but they have additional benefit in preventing cardiovascular diseases in diabetes patients, particularly those who have, particularly for secondary prevention. So that if there is cardiovascular risk, then you have to choose one of the SGLT2 inhibitors or GLP receptor agonists. If not possible, then at least something cardiovascular neutral. So if the patient, so going back to that patient, the HbA1c target was set as 7%. So he can lose weight because he was obese and he needs cardiovascular safety drug. So one of the two drugs were selected. So let's look at the last patient. So it is the 56-year-old female with type 2 diabetes and presenting with ankle edema and a BMI of 25 and blood pressure of 130/80 and HbA1c of 8%. And he has a eGFR, she has a eGFR of 40, which is CKD 3, and urine microalbuminuria more than 3, and she's on metformin, glycoside, and irbesartan, which is antihypertensive. So again, what is the HbA1c target? Are you worried about the weight gain or loss? And what is the renal safety or benefit? Again, going back to the guideline, if you can remember. So again, those who have CKD, you have to go ahead with drugs which has proven, something is missing, which has a proven benefit in patients with CKD, that is either again SGLT2 inhibitors or the GLP-1 receptor agonist. So this is one such study, Credence, where they trialed canagliflozin against placebo, and it has shown that it is very good drug in reducing albuminuria and also reducing the time for renal failure derangement and renal and cardiovascular death. So there are ample evidence to suggest that the SGLT2 inhibitors and the GLP-1 receptor agonists actually prevent the progression of the CKD. So if necessary, that is a good choice. So this patient again can HbA1c target is less than 7% and can lose allow weight loss because she was a bit on the overweight side, and for the renal safety, so the best drug of choice would be SGLT2 inhibitors. So having said all that, I think in our setup, what is most important is the cost and the access and the availability. So when it comes to that, I think in the hospital, probably when it comes to the second line agent, sulfonylurea is the most widely available one, and thiazolidiniones, that is pioglitazone, and of course insulin are the drugs that we are left with. So this is just to summarize all the effects of drugs on cardiovascular disease, renal and weight, and hypoglycemic risk. Just to give the few take-home messages. So the approach of choice of anti-diabetic agent should be individualized, and metformin remains, however, the first line of agent. And those who have high risk of established cardiovascular disease, CKD or heart failure, SGLT2 inhibitors or GLP-1 receptor agonist should be the second line of agent. And others choose the second line agent based on the weight of the patient and risk of hypoglycemia and the cause. And insulin should be, however, started promptly if failed to achieve HbA1c target. I think you will listen to about insulin in the next lecture. Thank you.